Good afternoon. I'm going to try and collate the information that I have on an important subject, which was well remembered on 13th of September as Sepsis Day. It's a complex subject, and I'll do my very best to add on the current guidelines and how to manage patients with various comorbidities. So I'm quoting and using the guidelines of NICE, which was reviewed in April of 2020, the UK Sepsis Trust, Sepsis 6 Pathway, and the American Critical Care Advice. So let's get on with the actual definition then and other things. So how does one define sepsis? The mnemonics would suggest slurred speech, extreme shivering, painful muscles, severe breathlessness, a sense of impending doom, and skin mottling. It has also been known as septicemia, blood poisoning, and through its ability to trigger clotting factors, disseminated intravascular coagulation. Sepsis 3 describes sepsis as a syndrome which is a life-threatening organ dysfunction produced as a result of dysregulated host response to infection, which implies some degree of lack of control. That would mean the organ might overact or underact. The two processes involved in producing sepsis, which are included in definition, are immune and coagulation systems are switched on by infection, and these result in dysfunction of one or more organs with variable severity. And into this category is enshrined multiple organ dysfunction syndrome. So what is the pathogenesis? How does it progress? Sepsis can lead to persistent hypotension despite the use of fluids given intravenously and inotropes administered as well. Inotropes are generally used to increase or stimulate the rate of heart contraction, the power of heart contraction, and therefore to improve the arterial pressure. And when the arterial pressure falls below 65 millimeter mercury, perfusion is impaired and anaerobic metabolism proceeds with a build of lactic acid. And so if the lactic acid goes above 2 millimole per liter, then various pathologies arise. Septic shock describes circulatory failure, which is a feature of shock, as well as cellular and metabolic abnormalities, which are associated with a risk which is mathematically much more than the risk from bacteremic or viremic sepsis. So septicemic shock is an add-on of circulatory shock and organ damage, which results in greater mortality than bacteremic shock. So how often does one see the effects of sepsis developing? So in the UK, the Office of National Statistics has reported around 150 or so admitted cases, but it also recognizes that 250,000 cases remain unrecognized. Of the diagnosed cases, 45,000 or thereabouts, one third die due to late presentation. And the sites most encountered producing the damage arise from respiratory, GI tract, genitourinary tract, hematogenous, skin, soft tissue, bones, and joints, and there are many others. So, for example, the excessive use of rescue medications, including various long-term antibiotics, catheter-based long-term antibiotic use, unnecessary use of antibiotics altering the gut flora, blood-related malignancies which reduce immunity, and often produce changes in the population of pus-producing modalities. So neutrophil increase and neutrophil depression is also possibility. So what are the causes that one usually encounters? So the pathogens would be about 50% bacterial, and of this group, 80% bacterial are the usual community-acquired organisms. Another way of looking at it is gram-positive organisms are normally Staph strep A, Pseudomonas, Strep pneumonia, Enterococci, and anaerobic Clostridia. The gram-negative organisms would be E. coli, Klebsiella, Proteus, Pseudomonas, Salmonella. And in children, Neisseria meningitidis and Haemophilus influenza are also common. Rarely, rather than bacteria, fungi, viruses, and parasitic infections also are contributory factors. There is increasing bacterial resistance produced in long-term and low-dose antibiotics, which are generally prescribed anticipating low-grade infection. This ends up the important use producing bacterial resistance, and the bacteria continue to thrive. There are some host factors as well, where the ability to fight such a challenge is significantly reduced. So extremes of age, less than 6, more than 80, genetics, comorbidities such as coincidental heart disease with reduced ejection fraction, use of cytotoxic medications or medications related to non-steroidal anti-inflammatory drugs, alteration in the genetics of the bacteria or the virus. And we have seen such an encounter with COVID-19 and its variants, Omicron and 2.286 COVID. Often it is blamed that the poor and risky environment, such as working where there is dust, dirt, or presence of challenging substances occupationally, would increase vulnerability. So what makes us more prone to finding patients who have increased risk factors? We've talked about age extremes. When self-care is diminished, particularly with Alzheimer's disease, learning disability, sense of denial, sense of neglect in mental health, as well as sensory deprivation, such as increasing deafness, increasing loss of vision, and non-availability of appropriate support. When someone is frail, much more than the age, there is pregnancy with redistribution of extracellular volume and its impact, and postpartum when there is change of the hormone circulation and the extracellular volume is different. So these are the times when there is a greater chance of bacteremia or viremia becoming sepsis. There are certain conditions which inherently alter and reduce immunity, such as with various cancers like blood cancers, diabetes, HIV, AIDS, jaundice, sickle cell disease, use of chemotherapies, steroids, glucocorticoids, and disease-modifying anti-rheumatic drugs, such as methotrexate. Also, if there has been multiple injury, such as roadside trauma, multiple salvage procedures, and use of iatrogenic infection, such as if the stent becomes infected, or if the nasogastric tube becomes infected, or the drain becomes infected. This category also includes drug abusers, or when there is an overwhelming supply of pathogens, such as in treatment centers. So with regard to identifying sepsis by way of clinical features, I would say that Sepsis 6 and the American publications mention of 4 markers, 3 red flags. The 4 markers are tachycardia, tachypnea, temperature, leukocyte excess, and 3 red flags: a newly or recently developed altered conscious level, referred to as confusion, high temperature, fast heart rate, or fast respiratory rate. Generally, features of shock would include low blood pressure, less than 90 systolic, fast heart rate, greater than 130 per minute, tachypnea, such as rate exceeding 25 per minute, but the temperature could also reduce or increase. Peripheral oxygenation level falls below 92 and the conscious level is reduced. So these are red flag features of shock. Features of infection would be raised inflammatory markers such as C-reactive protein, erythrocyte sedimentation rate, serum ferritin level, serum cobalamin or vitamin B12 level, white cell count, which is increased in predominantly with regard to polymorphonuclear neutrophils. The long-term sugar level is increased, the temperature is increased, and neutrophil count is increased. Clinically, which organs might be producing sepsis is reflected by urine developing, showing pus cells and protein, infection in stool or discharge from wounds, meningitis reflected by seizures and pus cells in the CSF. The general features of sepsis includes hyperperspiration, increased generalized pain, and loss of energy. So there are 2 slides in which I have described how best to diagnose sepsis. Please remember that suspicion is far more important than confirmed diagnosis because its management should begin straight away. So the diagnosis is basically clinical, and we must actively exclude short-term predictable loss of consciousness or alteration of consciousness called delirium. Infection would also be associated with rise of clotting factors, and there would be evidence of clotting peripherally, abnormal renal function tests, liver function tests, and reduced urinary output. The main symptoms would include high or low temperature, which means above 38 or less than 36, fast heart rate that is above 100. In this context, Sepsis 6 care bundle describes, on the basis of suspicion, the first hour since suspicion to be the golden hour, because many patients can be retrieved and salvaged. Beyond that, there would be organ damage, death, or possibly more suffering. So the care bundle requires measurement of oxygen, taking of culture, finding and administering antibiotics intravenously, and measurement of urinary output. One would look out for the sources, such as cellulitis reflected by burns and injuries, wounds with purulent discharge, ulcers, veins becoming tender, urine, sputum, or stool showing evidence of infection. However, if there has been a recent unexpected deterioration in the objective findings, such as temperature rising above 38.3 or falling below 36, oxygenation becoming less than 92%, systolic blood pressure becoming less than 90, or heart rate exceeding 90, respiratory rate more than 20, multiple organ dysfunction syndrome, cellulitis, and dermatitis, and reduced urinary output. The non-specific symptoms would be malaise, anhedonia, weight loss, anorexia, agitation, and changed behavior. Once again, I apologize for some repetition, but the golden hour is so important that it would be worthwhile mentioning some of these things again. So, if there's a significant recent unexpected deterioration in the parameters that I have earlier described, if there is presence of MODS, skin changes, changes of blood pressure and perfusion and oxygenation with non-specific symptoms that I've described, if there are symptoms of infection such as hyperpyrexia, immune depression, neutropenic sepsis. So the important thing, as Sepsis 6 has described, is to make assessment through risk stratification. And for these, there are several tools, and the common ones are frailty score, news 2 score, QSOFA for children, and of course, general assessment of low blood pressure, high respiratory rate, and reduced Glasgow Coma Scale score. Conscious level, when assessed through Glasgow Coma Scale, if the score is less than 14, 15 being normal, then cognitive tools would also need to be used. So, how does one begin treatment? This is also a repetition, but I consider it necessary. IV antibiotics for infection, comprising penicillin, ampicillin, clindamycin, metronidazole, gentamicin. According to the trust policy, imipenem cilastatin, which is Primaxin, or meropenem merem, which is a trade name, can also be used, and it's very popular in USA, and Center for Disease Control recommends it strongly. Along with antibiotics, inotropes such as dopamine should be used to increase the blood pressure if needed, insulin to stabilize blood sugar, corticosteroids should be used such as dexamethasone to reduce inflammation, and simple analgesias should be tried before stronger ones for pain control. NICE and Sepsis 6 advise us that sepsis can cause death within 12 hours. The value of the golden first hour cannot be overemphasized, and this is the teaching of critical care as well. So when one suspects presence of sepsis, either in the nursing home or patient's home or on the ward, active risk stratification, monitoring, and treatment should start. And this is the role of the golden first hour. As is advertised in the UK about fast, face dropping, arms not rising, speech becoming bad or slurred, then it is time to act, calling 999. In the USA, time is the mnemonic for getting hold of emergency services. Temperature, infection, mental decline, being extremely ill. Assuming that the patient hopefully improves due to timely intervention, then many patients, according to the Office of National Statistics, can take up to 18 months to improve from the post-sepsis syndromes, which can produce damaged organs, insomnia, nightmares, myositic pains, arthralgia, fatigue, listlessness, poor concentration, lower cognitive functioning, and lower self-esteem. So the complications of sepsis would include the organ damage dysfunction. So there could be clots, necrosis, ischemia, and gangrene of organs and digits and limbs. There is increased risk of superimposed infection. The first organ to show its failing would be the kidney, followed by the heart and the lungs. If someone suffers from sepsis and goes through the ritual of diagnosis, monitoring, treatment, then in such category, the mortality rate after 3 months is 1/3. So it is important to initiate the golden hour based management. So let's just look at something else. So I've mentioned that people who are frail should be prioritized first into being diagnosed with sepsis and also enhanced treatment. So the Dalhousie University has published this. So a person who is at scale 1 is someone who is robust, active, energetic, motivated, exercises regularly, and are among the fittest for their age. This is scale 1. Scale 9 is someone who is terminally ill and so therefore is entirely dependent. The life expectancy is less than 6 months and they are not being supported with family members, and so they are demotivated. Accordingly, in between, the higher the frailty score, the more energetic the treatment would need to be. So the actions needed according to sepsis 6 pathway, which I have already mentioned, is administer oxygen to keep the saturation SpO2 greater than 94%. And this would be the case in people who do not have comorbidities of COPD or respiratory fibrosis, because in them, if the SpO2 is kept around 88 to 92%, it might be sufficient. There should be blood cultures taken. Also, if there is neurological infection suspected, then CSF. Similarly, excreta checks such as urine culture, sputum culture, and if need be, chest X-ray and formal urine culture and sensitivity need to be done. Intravenous antibiotics, considering history of allergy and according to the protocol prevalent. Enough IV fluid should be given when there is hypotension to improve the hydration so that hyperlactatemia is reduced. So the serum lactate should be reduced by hydration. Over the range of 2 millimeter suggests hyperlactatemia. This represents anaerobic metabolism. Urinary output should be measured routinely as part of monitoring. So these are the 6 actions: oxygen, culture, antibiotic, fluids, control anaerobic metabolism, and urine output. So news, which is the other way, modern way of categorizing severity, is National Early Warning Score 2. If the respiratory rate falls below 21, and again, there are 2 categories: someone with COPD who's been taking rescue medication containing antibiotics and steroids, and these are the levels you need to aim for. If systolic blood pressure is less than 120, then possibly fluid restoration as well as inotropic use, such as dopamine, might be needed. Pulse rate, if it is less than 60, that is low, that is bradycardia for the purpose of news 2. More than 100 is abnormal according to the news 2. Level of consciousness or new confusion is the chief thing which enhances the score. We have already talked about temperature. Normal is in this range of 36.1 to 38 degrees Celsius. More than 39.1 is hyperpyrexia. Less than 35 is high reduced temperature. If when initial sepsis 6 bundle has been provided or is in progress, if BP continues to be less than 90, conscious level does not improve, respiratory rate is still above 25, or serum lactate not reducing, then one should start the proceedings of intensive care and active, more frequent monitoring and enhancement of treatment, and a reappraisal of the findings as they come in from the laboratory. You may want to look at it at a later stage. So if you are providing oxygen using a nasal cannula, and if you are providing oxygen at the rate of 1 liter per minute, the flow rate is 1 liter per minute, and it ends up increasing the saturation by 24%. And so, as you can see, by using other methods, different valves and masks, the rate of flow and oxygen delivery changes. So, what are the cardiovascular parameters which one should take heed of as far as news 2 is concerned? In this, the diastolic blood pressure is not taken into consideration, but 120/80 is normal, ranging to 90/60. Below that is abnormal. If the blood pressure is more than 180/110, then there is hypertensive crisis. As far as pulse rate, heart rate is concerned, we have already mentioned and discussed it. There is a lethal pulse rate, asystole, VT, VF, or torsade. So, using the advantage of Glasgow Coma Scale, there are two aspects. One would categorize patients with the eyes, response to verbal commands, spontaneous motor response, and total score. So, with GCS eyes, if a person, despite being shouted at, such as open your eyes, does not open the eyes, then the level is 1. And if a person on verbal command, spontaneous or sort of on his own opens his eyes, then the levels are increased. So the more you go towards 15, the more normal you would be. So the second aspect is, what does one do? What does the patient do with verbal commands? If there is no response, such as to open your eyes, lift your hand, who are you? If there is no response, then it is score 1. If the person appears to be orientated in time, place, and person, then it is score 5. Motor response level in relation to causing pain or provoking the patient. If in spite of rubbing on the chest, pinching a safe area, if there is no response, then the score is 1. If the person obeys commands, the score is higher. So the total score of all of these in a normal person would be 15. If someone scores less than 8, they are comatose, very confused. If a person scores 3, he is unresponsive. You may choose to use the temperature as well, where if the temperature objectively is between 36.1 to 38, that is considered normal. More than 39.1 or less than 35 would be abnormal. Cold is worse. So a working example, and you will have many opportunities of checking it against a calculator. I will provide the link for the calculator. So you'd be able to score various things which matter in sepsis 6. So in this example of a 52-year-old male with fever, cough, and pleuritic pains, if the observations are such, then the NEWS 2 score would be 6. So the best way forward is to go to this link and then put in various parameters so you could calculate the overall score. So I must thank you for your patience. It's a tough subject, and obviously you need to remember a great deal of this, but it will come to you naturally as you see patients in this emergency, and hopefully you will learn more from reading and taking note of the presentation than actually finding patients. We are hoping for the patients to be less and less in number, but the age of the population is rising, challenges are increasing, and therefore it's difficult to say if there will ever come a time when we'll not see any patient with sepsis. In this regard, you need to remember the golden hour and its importance, and I must read this. If this particular patient with diagnosed sepsis has capacity for decision making, such as your suggestions of urgent hospital admission, then you will do your best to explain fully, and that would be part of informed consent, and then to respect the adult patient's right to choose. This is in accordance with the law. Their choice does not need to meet standards of being popular. If they have capacity, they have right to choose. If they do not have capacity, you will be exercising the best interests principles and either admit the patient under the Mental Health Act 1983 or abide by the power of attorney when the person has lost capacity and the view expressed by the patient during his capacity. Thank you very much. So the whole idea of making this presentation is to encourage you to revise, to calculate the scores of NEWS 2, to disseminate information, and to put it into practical application. Thank you very much.